So today we're going to be looking at physical assessment of the newborn. When we talk about physical assessment as a whole, what exactly are we talking about? Every individual at different developmental stages of life do require physical assessment every now and then. So what exactly do we mean by physical assessment? In this case, for a newborn, think of physical assessment as a thorough and skilled observation of the newborn. And not just for the newborn, think of it as a thorough observation of an individual at different stages of life. But for today's aspect, we're going to really be concentrating on solely newborns and infants. What are some of the reasons why we require to do a physical assessment? We do a physical assessment in order to try to identify any presence of congenital disorders or anomalies that might be present in the baby or the newborn. We could also carry out a physical assessment in order to assess the extent of gestation, labor, delivery, and analgesic as well as anesthetics that might have affected the infant during delivery. We could also carry out a physical assessment of the newborn to try to assess the presence of any signs of an infection or metabolic diseases. It could also be to ascertain a successful transition into extrauterine life, usually within the first 24 to 72 hours of delivery or of birth of a newborn. A physical assessment is required to be carried out. Again, being able to carry out this physical assessment as early as possible would allow the physicians, will allow the healthcare providers, the nurses, the midwife to, catch early, like I like to put it, any potential disorders, infection, congenital anomalies, or whatever might be present in the child. So technically, within the first 24 to 72 hours, a lot is going to be happening with the newborn, and one of which is a physical assessment. In order for us to commence this, the first thing that needs to be done to this baby, to the newborn, would be to measure the vital signs. We need to take the vital signs reading for this baby. Starting with the temperature, we're going to need to take the pulse, we're also going to need to take the blood pressure reading, we're also going to take the breathing reading, also respiratory, and we're also going to check the oxygen saturation of the baby. And then moving on from here, we will go ahead and do what is known as an anthropometric measurement. Anthropometric measurement is basically the measurement of the head circumference, the chest circumference, the abdominal circumference, the length of the baby, as well as the baby's weight. It is generally believed that babies usually weigh an average of about 7 pounds upon delivery. Also, it is generally believed that the average length of a newborn is somewhere around 51 centimeters or 20 inches. Now, we've talked about a physical assessment, what it is. We've talked about the objective as to why it's done, why it's necessary to be done. We've talked about, the time at which physical assessment is actually done for a newborn, which is within the first 24 to 72 hours that needs to be carried out. Now, before I actually show you a demonstration of how to perform a physical assessment on a newborn, I would like to run you down through the systems as we're actually going to be doing this. First of all, the first thing we're going to do upon implementing the skill would be to start with a complete observation of the infant, of the newborn's general appearance. Meaning, we're going to observe the newborn's general appearance from head to toe. We're going to observe the skin color, we're going to observe to see if the newborn is active, we're going to observe the muscle tone, any kind of activities that the newborn is actually displaying. If the newborn is conscious, if the newborn is unconscious, if the newborn is alert, awake, if the newborn cries or not cries. We're going to look at the skin color, the texture of the skin, look for any abnormalities, see if there's any signs of rashes or any kind of skin disease ongoing presently. Then from the skin, we're going to scale down to the head. Looking at the head and the neck, we're going to look at the appearance of the head, the shape of the head. There are tendencies for the shape of a newborn's head to seem a bit misshapen. So this is what we're looking at. We're also going to look at things like the open soft spots between the bones of the baby's skull, right? There are a number of soft spots between the bones of the baby's skull. Then we're going to look at the bones across the upper chest and the clavicles for any deformities, if it's broken, fractures, or anything like that. Then we're going to go scale down to the face. When we're in the face, we're looking at things like the eyes, the ears, the nose, the cheeks. We're looking for presence of red reflex in the eyes, and we're going to do this with ophthalmoscope. Now, upon observing the face, observing the eyes and the ears and the nose, then we're going to scale down to the mouth. We would be using our index finger to feel the roof of the mouth. We're going to be feeling feeling for the soft palate. We're going to look at the tongue, and we're also going to observe the throat. Now, upon observing all of this, then we're going to scale down and we're going to look at the lungs. Listen to the lungs, I mean. Take the respiratory rate, compare the respiration of the baby. If it's, if it's regular, then we're going to listen to the breath sounds as well as the breathing pattern. Now, from the lungs, still in the thoracic region, we're also going to listen to the heart sounds. We're going to listen to the heart sounds. We're going to listen for the femoral pulses. We're going to feel for the femoral pulses as well, which is usually found in the groin area. Then we're going to scale down to the abdomen. We're going to check for presence of masses or any kind of hernia. And finally, we're going to come down to the genital and the anus, checking the passages, for urine and stool, check for any abnormalities or any deformities in this area. Now, it's not just going to end right there. While we're observing all these different systems, we're also going to check for reflexes. There's quite a number of reflexes we expect to find in the baby. As with every other nursing skill, we're always going to need to gather our supplies and equipment. In order for us to carry out physical assessment of the newborn, we're going to need quite a number of supplies, which you could actually see listed on your screen right now. We're going to need to gather a nasogastric tube, clean gloves, tongue depressors, an otoscope. We're also going to need an infantometer, which we're going to use to measure the length of the baby. We're going to need a tape measure, a scale, a pen light, a thermometer, a warming device, or a warm blanket to keep the baby warm, because we're going to be exposing the baby now and again. We're also going to need an ophthalmoscope. We're going to require a blood pressure curve, preferably 2.5 centimeter wide, a suction bulb, a blanket or sheet, or a warm blanket could do for that, and a stethoscope, including a watch or a clock in order for us to take our pulse, vital signs reading. Just again, prior to every nursing skills, we also need to carry out an assessment. Some of the assessments we're going to be carrying out before we actually embark on this skill will be to note the type of delivery the baby was born through. There is a need to observe for any form of injuries due to difficult deliveries, if in case the baby, the mother has a difficulty in delivering the baby through normal delivery. It's also important for us to note the time and type of rupture of the membrane. Why is this important? If there's an increased exposure within the membrane, there will be an increased risk of infection. Also, we're going to need to make an assessment of the time and type of rupture of the membrane. Why is this important? It is important because increased exposure to infection, which may require special care for 12 hours or more as a result of ruptured membrane. Upon completing a thorough assessment prior to every skill, just as you do for every nursing skill, then you're going to plan. What are some of the things you're going to need to plan towards this? For starters, you want to ensure that the room temperature is somewhere around 32 to 34 degrees centigrade. Or you ensure that there's a radiant warmer nearby in order to keep the baby warm, because again, like I said earlier, you're going to constantly expose the baby throughout the duration of this physical assessment. You'll need to gather your supplies, carbolize the surfaces of any countertop you're going to be using, ensure that it's disinfected, prepare your scale, be cleaned, lined, and properly calibrated. And then we're going to start with implementation of the scale. Okay, so in order for us to actually commence physical assessment on our newborn, Majority of the time, the newborn is actually rooming with the mother. So the first thing we're going to need to do would be to speak with the mother or the parents of the newborn, explaining to them exactly what we're going to do and why we're going to do it. And we also need to get a consent in order for us to go ahead and carry out the physical assessment on the newborn. Also, we're going to need to identify the neonate's name or identify the neonate by going with the name band, the name tag on the wristband. Also, this also would have to be cross-checked with that of the mothers to ensure that we have the right patient. This is one of those unique situations whereby you cannot be like, hi patient, I'm here to carry out a physical assessment on you. Can you please tell me your name? No, because this is an infant, it's a neonate. The patient won't be able to tell you their name. If anything, they probably just cry, right? So you would go by the name tag, by the ID band on the wristband, and also by also confirming from the mother, which you would have initially explained to what you want to do, why you want to do it, and gain their consent. You always have to gain consent for almost every nursing skill you perform on your patients. Now, moving along, already we provided privacy. Again, like I mentioned earlier, this baby might actually be rooming in with the mother. So upon getting consent from the mother, you would actually carry the baby with a bassinet and transfer the baby to a bed where you're actually going to be carrying out the physical assessment. Now, before you even touch the baby, please ensure you wash your hands according to the guidelines. Wash your hands properly and don your gloves. And then you're going to remove the baby's clothing, ensure the room is warm, and ensure you have a warm blanket next to you, because when you're not actually touching or doing anything with the baby, it's always good for you to periodically cover up the baby to prevent heat loss, right? So ensure you have your hand washed properly, put on your gloves, take off the clothing of the baby, and you do a complete observation of the patient's general appearance. Okay, so moving ahead, if you take a look at the skills checklist that was provided to you prior to the class, you would notice that right after doing a complete general observation of the newborn's appearance, we're going to start with respiratory system. However, I always advise that during the physical assessment of a newborn, prior to you start touching the baby, it's always good for you to do any form of auscultation that you might need to do. What do I mean by that? Listen to the lung fields, listen for the heart sounds, listen for blower sounds. It's preferable to do this at the beginning of your assessment, because by the time you start touching the baby and fondling with the baby, there's tendency for the baby to start crying, or the baby to react in such a manner that would mean that they don't want you touching them. And sometimes the baby might be asleep prior to you starting your physical assessment. It's usually preferable for you to do any kind of auscultation you want to do, as also it's good for you to take a vital signs at the same time. You could take the vital signs at the beginning of your skill, just the same time you're doing the anthropometric measurement, or you could do the vital signs at this stage. The anthropometric measurement also could be done at the end of your skill if you want, but it's usually preferable to do this at the beginning of a physical assessment of a newborn, because at that time the baby is still sort of calm, if you want to put it that way. So at this point, we will be observing the respiratory system. We're going to be looking at observing the symmetry and shape of the thorax. We're doing this to see if there's any kind of deformities, such as presence of a barrel shape or anything like that. We also want to assess the patient's breathing pattern, how the baby actually breathes. Then of course we're going to auscultate. The minute you start auscultating, might as well auscultate the lung field, auscultate the heart sounds, as well as auscultate for the bowel sound at the same time. So again, one thing I didn't mention at the beginning is that prior to you even doing anything on your baby, prior to even starting it, after you've collected the baby from the parents and explain to the parents what you're going to be doing and gain their consent and all of that, wash their hands, all those preliminary stuff that you need to do. You also want to observe the patient's level of consciousness. A baby's level of consciousness could be described in different terms. You could describe his or her level of consciousness as crying. You could describe his or her level of consciousness as quiet alert, or you could describe his level of consciousness as active alert. Crying simply means crying. But if you're going to describe it as an active alert, that's like when the baby is awake and baby is actually actively doing something. It could be breastfeeding, could be just giggling, could be, you could also be crying, but the baby is alert. Quiet alert would be that the baby is actually alert, the baby is awake and alert, but the baby is really not doing anything. Baby's just, trying to figure out what you're doing or what you're about to do with them, something like that. So that would be some of the ways you could actually describe the baby's level of consciousness. So while you're doing these auscultations, such as the auscultation of the lungs, auscultation of the heart, auscultation of the bowel sounds, it might be important for you to take any vital signs reading that you might not have taken. So for example, while you're auscultating for the lung field, then it's best for you to actually count the respiratory rate during this time, right? And you would actually have to count this for 1 full minute. The same thing applies to the heart sound. When you're auscultating for the heart sound, you might want to count the pulse rate or at the point of maximum impulse, which is usually left of the mid-clavicular line in the fore-intercostal space for infants, for newborns and infants or children less than 4 years old. Why is it important for us to do this now before we actually start getting too deep into the whole, physical assessment? It is common to find infants actually crying when you actually start touching them a lot, like I mentioned earlier. And when an infant starts to cry, you're going to find that you may or may not get an abnormal respiratory rate reading. So if it does happen that while taking the respiratory rate of a newborn or an infant, the newborn started crying, it would be best for you to try to calm the baby down. Calm the baby, stop the baby from crying so that you could take the best possible, the most accurate respiratory rate possible. Infants are mostly considered, or newborns actually, pretty much most newborns are considered complete nose breathers. So it's very important to also have it in mind that nasal obstruction can be sort of a little bit of a problem for them. Now also, while taking the respiratory rate of a newborn, while you're carrying out a physical assessment on the baby, it's good for you to understand that some newborns display what is known as a periodic breathing. And what do I mean by periodic breathing? Periodic breathing is actually a situation whereby for a few seconds you would find that there would not be any respiration going on. Like there will be, for a few seconds that the baby won't be breathing. This condition is normal. It actually can be normal, provided that for those times that happens, the baby does not turn cyanotic. Once there is no signs of cyanosis, then it's fine. If there is cyanosis, then it's not considered normal. It's considered abnormal. Even though periodic breathing for newborns can be normal, it's also important as nurses, we should also inform the parents to constantly keep an eye over the baby, monitor those episodes of periodic breathing. If they start to become too long, if the length between each episode of periodic breathing, if the length of each episode of periodic breathing extends more than what it used to be, or if it starts to extend over time or start to increase over time, then it's important for the parents to alert the medical practitioners, the physicians or the pediatricians or something, to see if something is getting worse with the baby. Also, it is also very important for us to know that infants, newborn, even young children, they tend to use their diaphragm a lot for both inhalation and exhalation. So it is necessary for us to look out for this. So with that, having said that, in place of actually having to use your stethoscope to listen for a whole 1 minute for the respiratory rate, while you're taking the respiratory rate, you may decide to just place your hand on the patient's, on the newborn's abdomen and feel for the rapid rise and fall during respiration. That could be another way for you to actually measure the respiratory rate for the baby. So when it comes to actually listening to the lung sounds, we're going to require a pediatric stethoscope. But if you don't have that, you could use any other regular stethoscope, but you're going to need to use the bell portion of your stethoscope. Okay. So upon exposing the infant's anterior thoracic wall, you're observing for symmetry and shape of the thorax. You know, you're checking for any form of any kind of deformities, or maybe a barrel shape of the chest or anything like that. Okay. You also want to take a look at the patient's breathing. You want to take a look at the nostrils, see if there's any form of nasal flaring, any grunting from the baby, any supraclavicular, any intercostal and subcostal retractions as you're observing the thoracic wall. All of this you're looking at for as you're observing the baby. Now, then we're going to listen for any audible breath sounds, again using your stethoscope, the bell portion of your stethoscope. Now, the tricky thing about this when it comes to the newborn or the infant is that they're not as big as adults, okay? So you find that an infant normally seem to have a very loud heartbeat, and it tends to sometimes overwhelm or overshadow the lung sounds. So it makes it a little bit difficult sometimes to listen. So I would advise that for the most part, when you're going to listen for the lung sounds, for the breath sounds of an infant or of a newborn, you listen on the sides. However, you could also listen just the same way you would listen for an adult, starting from the apex of the lung. And every time you listen for the respiratory sounds, you have to listen from side to side and from top to bottom. And as you're doing this, you're comparing. And while you're doing this, do not listen over any bony prominences. Do not listen over any bony structures, such as maybe the scapular or over the ribs. You would preferably listen in between the ribs, meaning the intercostal spaces. So you listen here, and you listen on the other side. And then you're going to listen from top to bottom. So when you're going to the bottom, you're going to the side. And then you're going to listen to the other side, and you're doing a comparison, right? So at this point in time, it will be preferable for you to actually count the respiration of the baby for a whole 1 minute, since you're already here. So this is the point where you actually get to take your respiratory rate. So as you're listening to see if there's any grunting sounds, any wheezing sounds, any stridor, high-pitched inspiratory sounds, any sort of obstruction, lack of breath, things like that, difficulty breathing, presence of any respiratory distress. Some of those sounds will indicate that. So that's basically what you're listening for. Irregular rates will be considered respiratory rates that are more than 60 breaths per minute, or presence of apnea, which is a situation whereby there is no respiration for more than 20 seconds. So after taking the respiratory rate, then since we're already doing our auscultations, might as well go right ahead and auscultate the heart sounds, and as well as auscultate for bowel sounds. For the heart sounds, we're going to need to auscultate at 4 different points. It's also important for us to note that the regular heart rate for a newborn is between 80 to 180 beats per minute. Some texts have it as 100 to 180 beats per minute. But on average, most newborns would average around 120 to around 140 beats per minute. So we're going to start by auscultating at the second intercostal space, right sternal border for the aortic valve. The sternal border is right midline of the ribs. There's a video that I've done that shows how to identify the different landmarks, starting from the angle of Louis. So you may want to take a look at that video just to better understand how to navigate around the anterior thoracic wall of an infant or of an individual. So anyways, so we're going to auscultate for the aortic valve. The aortic valve is actually found on the second intercostal space at the right sternal border. This will be the right part of this individual, and this will be the left side of this individual. Like I said, the sternum is right in the middle between basically holding both the ribs from both sides of the body together, right here. So the right sternal border would be on this side of the sternum. The left sternal border would be on this side of the sternum, which would be on the left hand side of the individual and on the right hand side of the individual respectively. So that is where we're going to listen for the aortic valve. So, but we're going to listen at the second intercostal space. Now again, if we know how to find the angle of Louis, then it's going to be easy to find every other part of the anterior thoracic landmarks that you might be looking for. Just a quick recap. So we'll listen at 4 different points. At the second intercostal space, right sternal border for the aortic valve. Still at the second intercostal space, left sternal border for the pulmonic valve. And then we're going to listen still on the sternal border, the left sternal border, but this time at the fourth intercostal space, we're going to listen for the tricuspid valve. And then we're going to move from the sternal border from the left hand side to the mid-clavicular line for the mitral valve. Now, for an adult, you expect to hear the point of maximum impulse right below at the fifth intercostal space, right along the mid-clavicular line. However, for an infant, you want to listen more to the left of the mid-clavicular line, about 1 centimeters from the mid-clavicular line. That's where you're supposed to hear the maximum impulse. And then lastly, for auscultation, you would auscultate for bowel sound, since we are actually doing auscultation right now. So it would be good for you to auscultate for the bowel sound as well. So you would auscultate just the same way you auscultate for an adult, by going clockwise around the 4 quadrants of the abdominal wall, going in a clockwise position. Okay? So upon listening at all these 4 points, then what we're going to do is we're going to need to palpate the femoral artery, and also we're also going to need to palpate the brachial pulse, and we're going to need to take the reading for the femoral artery and take the reading for the brachial pulse and compare. We want to make sure that they're not far apart. Okay, so to check the femoral artery, we're going to need to strip our baby. Now, for the femoral artery, this is the same thing for a full-blown adult, how you're going to do this. So in order to assess for the femoral artery, you need to find the anterior superior iliac spine and the symphysis pubis. You're going halfway between the anterior superior iliac spine and the symphysis pubis. So the anterior superior iliac spine is right at this corner, whereas the symphysis pubis is right at this corner. So halfway between this would be where you would find your femoral artery. So how do you find the brachial pulse or the brachial artery? You lift let's use this, it's much better. The brachial pulse is done by, okay, let me use my arm for this. There are a couple alternatives to this. First, you could either find the portion of the upper arm where the biceps sort of meets with the triceps. At that junction, that point right there, you would have the brachial pulse. So what you'll find you would do is you would actually use your fingers, and you're going to feel for the point where the triceps and the biceps sort of meet, and you're going to apply a little bit of pressure, and you should be able to feel the brachial pulse. So technically, this usually would be about 2 centimeters away from the antecubital fossa right here. This will be your antecubital fossa. Now the other option is to draw an imaginary line from your pinky straight up 2 centimeters above your antecubital fossa, and you apply a little bit of pressure right there, and you should be able to feel the brachial pulse. So you draw an imaginary line straight and you apply pressure, just a little bit of pressure, and you should be able to feel, yeah, right there, you should be able to feel your brachial pulse. It's about 2 centimeters above the antecubital fossa. So you could do the same thing with your baby, or you could simply just use your fingers to feel for the upper arm and feel for the point where the biceps and the triceps sort of, joins. It's usually about, for an infant, it's less than the 2 centimeters, of course. So you apply a little bit of pressure and you could find the brachial pulse right there. So now we're going to continue with a physical assessment of the newborn, literally starting from head all the way to the toes, okay? For sake of time, I'm going to put this away because this is not exactly a real baby. So I'm going to put that away, and I'm going to have this babe mannequin exposed throughout the duration of the skill. But this, again, is for educational purposes. So I would like for you to know that when you're performing a physical health assessment of a newborn, it's very important for you to put into consideration the temperature of the room as well as the temperature of the baby in question. So now we're going to start by exposing the head, and we're going to observe the head for symmetry. We're looking for any signs of swelling, any abnormalities, any possible caput. Caput is actually when there is a swelling of the scalp and of the newborn scalp. There's also what is known as cephalohematoma, which is usually when there's a blood collection between the periosteum and the periosteum of the skull bone and the skull bone itself. So we're looking for things like that, signs of some different abnormalities like that. And then on observing that, we're also going to observe the fontanelles. We're going to observe the suture lines. The fontanelles are this little soft spot right here. You have 2 of them. You have one in the front, which is known as the anterior fontanelle, and you have one to the back, which is also known as the posterior fontanelle. You're looking at both fontanelles and you're making sure that they appear to be intact. The reason why the fontanelles are there is that they're there to allow molding of the head of the baby when it's passing through the birth canal. So it makes it easier for the head to pass through the birth canal. Now, joining these fontanelles are what is known as the suture lines. The suture lines, think of the suture lines as borders that joins the different bony plates together. So during delivery, there's tendencies for the bony plates to actually overlap, overlap each other, and this forms like a little ridge, basically, making it easy for the head to pass. The tendencies are that sometimes the head get compressed as it passes through the birth canal. So this makes those bony plates overlap at the sutures and create like something that seems to be like a small ridge. So you might also want to check the suture lines. As you're actually observing the patient, you might want to run your fingers over the suture line to see if there's any abnormal closure of the suture lines. Most of the time, it takes usually roughly about 2 years for the suture lines to be to start closing up, because at this point in time, they're already becoming bones. So before we move further, I thought it's wise to actually tell you the names of the suture lines. You have one right here to the front that's actually splits the frontal bones into 2. This is known as the metopic suture. This is known as the metopic suture, and you can remember that by remembering that it actually splits the frontal bone in 2. Then you have this one that run across the parietal bones. These are the parietal bones. So you have this suture line that joins the anterior fontanelle to the posterior fontanelle, and this suture line is known as the sagittal suture line. I always remember this with mohawk, basically, the hairstyle for men. So think of this as sagittal suture. This is a sagittal suture. So Joining that sagittal suture, again remember it separates the parietal bones. These are the parietal bones. Now joining this sagittal suture with the posterior fontanelle would be the lambdoid suture. The lambdoid sutures are the ones that are actually separating the parietal bones from the occipital bone. So you have the lambdoid sutures, you have the sagittal sutures, and you have the metopic suture, and last but not the least, you have the coronal suture. This will be the coronal suture, which actually separates the frontal bones from the parietal bones. So this will be the coronal suture. In the event or in the case of a breech birth, it's also important for us to assess for craniotips. Craniotips are basically softening or thinning of the skull of an infant or a newborn. So, and sometimes they may be associated with hydrocephalus, congenital syphilis, or rickets. Now, we're going to move on to the eyes. We're going to be looking at all the features on the head, such as the eyes, the nose, the mouth, and the ears. So we're going to start with the eyes. Now, this portion of the assessment is best done with the newborn's parent available, maybe the mother or the father, somebody available, or maybe a fellow colleague or a fellow nurse, because you're going to need the baby to be held in a sitting position, and so you're going to need the baby to be held in a sitting position while you do some of the checks. For example, you're going to need to do a red retinal reflex check. You're going to need to evaluate pupillary reaction to light. It's best that you have somebody assisting you with this while you go ahead and perform the skill. However, we're going to make do with what we have at the moment. So bear in mind that it will be important for you to get assistance with this portion of the skill. Okay, so this is what I decided to do. So I have this to support my baby. It's very important that you dim the light in the room in order to assess the red reflex as well as the pupillary reaction to light. It's best that you have the light of the room dim. So the first thing we're going to do is to assess for the doll's eye reflex. The doll's eye reflex is a reflex that is elicited when you move the baby's face to the opposite direction. You turn the baby's head to the left or to the right, and you expect the eyes to move to the opposite direction, meaning that you will turn the baby's head to the baby's left, and you expect to see the eyes, both eyes, turn the opposite direction, meaning to the right. And you're going to do the same thing on the other side. You turn the baby's head to the right hand side, and you expect to see that the eyes move to the left. So this is also known as the oculocephalic reflex when you're testing for cranial nerve 3 and 4. An alternative to this is, I'm going to use another doll, another model, and you could take a look at this. An alternative to this would be that you have your baby, and you move closer to the camera, and you have your baby. When you tilt their head backward, or alternatively you extend their neck, you expect to see that their eye closes as if though they're going to sleep, as if though you're deceiving them to make them think that you're going to lay them down to sleep, something like that. Anyways, so when you tilt the baby's head backward, the neck backward, you expect the eyes to close just like in the dolls. And when you raise the head back forward, then you expect the eyes to actually open up. So that would be an alternative way to testing for the oculocephalic reflex, which is also known as the doll's eye reflex. So absence of this reflex is actually signifying some abnormalities with the brainstem. So moving on from here, we would go ahead now and assess for or evaluate for pupillary reaction to light. We're doing this to also assess for the functions of the third cranial nerves. So in order for us to do this, we need a pen light basically. I do not have a pen light right now, so I'm just making use of my ophthalmoscope for this. So what you basically want to do, again, remember the room will be, the light in the room have to be dim, and then what you're going to need to do would be to approach the patient's eye from an angle. Have the patient looking at looking straight ahead of you, ahead of them, and then you're gonna approach the patient to the patient's eye with a light. Just as though. You don't want to hold it onto the against the eye for too long. You just shine it from the side, and what you're looking for is you want to see the pupils. You want to see if they're gonna dilate or if they're gonna constrict. In the presence of excessive light, you expect the pupils to constrict. In the presence of no light or very low light, you expect to see that the pupils dilate in an effort to take in more light to promote or improve the patient's vision. The same thing you're going to do on the other side. You're going to come from the side and you're going to look. You flash that light on the eyes and you're going to watch to see if the pupils constrict. So again, in the presence of excessive light, you want to see that the pupils constrict. In the presence of very low light, you want to see that the pupils dilate. So upon flashing the light on the pupils, they constrict, and then once you take it off, gradually after a while, the pupils tend to dilate because there's no longer that excess ray of light on it. So that would be how you evaluate for pupillary reaction to light, and you want to ensure that both eyes actually have pupillary reaction to light. And then the last thing we're going to do would be to assess for the red retinal reflex. Safety is very important. Again, like I said earlier, this skill is one that requires an assistance from a colleague, a fellow nurse, the parent, somebody next to you and helping to keep the patient or the baby in a seated position. Okay, this is just for demonstration purposes only, and a baby should not be left in a seated position at the edge of the bed, supported with the bed with a pillow just like this. Okay, so what you want to do is with your ophthalmoscope, you're gonna select the brightest light setting on your ophthalmoscope. You're gonna use the medium to the small ray, as you can see, and then you're gonna get as close to your eyes as possible with the ophthalmoscope and move as close as possible to the baby's eye. So when you're observing the red retinal reflex, what you want to do is you want to use your right eye to observe the baby's right eye, and you're going to use your left eye to observe the baby's left eye as well. So this is what you basically need to do. You need to have this as close to your eye as possible, and then you are going to move in as close as you feel as you might need to, and you're going to observe. When you're doing this, think of it as looking through a keyhole and trying to observe everything in a room just through a keyhole. You will realize that if you want to see more, you're going to have to move around, but at the same time, your sight or your vision is directed at the keyhole. So this is basically what it looks like in this case. You're looking through the pupils and you're trying to look into the retina, and you're looking for that red reflex. Okay, so that's what you're basically doing. Have this as close to your eye as possible, and you move in. Now, to check the left eye, you're going to need to switch the ophthalmoscope also to your own left eye, and you're going to move as close as possible to the baby's eye. But again, this is not a real baby, so I don't expect to find no red reflex, but I'm just using this as an educational purpose. So this is how you would assess for the red retinal reflex. Now, abnormal findings would be that if there's any presence of a displaced corneal reflection, or if there is any kind of dark patches that is present within the reflex. That would signify an abnormal finding. So in essence, a normal finding in this case would be that there is absolutely no overall difference in the brightness and color of both eyes. That is what you're actually looking for. We're now going to move on to the ears. The ears is actually this pretty easy to examine. We're going to need an otoscope for that to look into the ear canal. But basically what we're going to need to do is to assess, again, start by observing the ears. Take a very good look at it. You always have to observe, make sure there's no deformities or note any abnormalities or any malformation of the earlobe. Assess for placement using your index finger by just running your index finger down the length of the pinna of the ear. And while you're doing this, you might also want to assess the cartilage to ensure that it's actually soft. And then check to see, make sure that the ears are at about the same height. Assess for any low set ears that may signify any genetic conditions, maybe something like Down syndrome and things like that. So keep an eye out for that. So you assess all of that, you observe the ear, and then we're going to need to observe the ear canal. In order for us to observe the patency of the ear canal, we're going to need to pull the pinna down. In adults, you would actually pull the pinna up. In adults, you would pull the pinna up and backward. You pull it up and backward, and it sort of helps the ear canal assume a much straighter passageway, basically. But for the newborn or for the infant, you just basically just pull down. So you would pull the ear canal, you pull the pinna down, and then with the use of an otoscope, you're going to observe the ear canal of the newborn. So basically, all we need to do would be to pull down the ear canal, and with the use of an otoscope, we would look into the patient's ear canal. Ensure that while you're doing this, you do not insert the otoscope all the way into the ear canal for sake of not damaging the eardrums or causing the baby any kind of injuries. So we did say that the last thing we're going to need to check when it comes to the ear assessment is the molar reflex. For much better position, you might actually have the baby positioned this way so you could maintain a visual field of the baby. So you could clap, and you're going to see the baby startle, or you're going to see the baby throw out both arms with the palms facing up in response to that noise that you just made. And that is eliciting molar reflex. One thing also that I need to tell you is when it comes to assessing the pinna of the ear, how do you know if it's lower down in the case of potential Down syndrome baby, or in the case of a congenital defect of the baby? You want to check the outer contours of the eye, and you want to see that it's in line with the ear. So that's how you could tell to see if it's lower, if it's too lower down, or if it's lower than where it should be. So basically, you want to ensure that there's a straight line between the outer contours of the eye all the way to the ear. So once you have a straight line, then it's fine. So another thing we needed to assess when we're assessing the pinna, the ear of the baby, is that we would bend the pinna and let it go, and then you're gonna notice how quickly the pinna retracts back to its original position. Now you're gonna find that in some cases, maybe cases of a preterm baby, or cases where there are some sort of congenital defect, there's possibility for the pinna to retract much slower than it should. So you want to see that the pinna actually retracts quickly as you let go the pinna after bending it.